Good afternoon, everyone. First of all, thank you very much for the invitation here, and forgive me because after 10 years in Abu Dhabi, living in Abu Dhabi, because I work at Cleveland Clinic Abu Dhabi for 10 years, is my first time in Kuwait. I'm really pleased, I'm really honored to be here. I'm honored because it's my first time giving any lecture in a boat, which is something to remember. And remember that I'm a surgeon, and I need to talk about diabetes. So we'll talk later with Dr. Jamal, because this is a trap. Thinking about the surgeon, speaking about diabetes could be tricky, so first, forgive me for any mistake. So let's wait a minute. It should start.
Could eating a lot of sugar actually cause my diabetes?
Eating a lot of sugar definitely does not cause diabetes if you don't eat so much sugar that you gain weight. And in fact, sugar to a certain extent is okay because it stimulates the pancreas to make more insulin, which actually helps control the blood sugar. And so actually you need a certain amount of carbohydrate in your diet to have your pancreas working normally. What I always tell people is that, especially if you're at risk for diabetes, I have people tell me all the time that, I've got a family history of diabetes, so I watch how much sugar I eat. And I say that that's not the right focus. The focus for you should be to make sure you keep your weight down. Because people who have a family history of diabetes, if they stay thin, have no more risk of diabetes than the general population. But if they become overweight, then their risk is 10 times higher than in the general population. So you can make a difference of 10-fold in your risk of diabetes if you've got a family history. If you stay thin, it's good. If you gain weight, it's bad.
Look at that. So sugar doesn't cause diabetes. The real thing is that what I mean with this, I don't know if it's true or not. So you still think there's no problem. But if you gain weight, then there's a problem. What I want to mean is that nowadays, type 2 diabetes, it's linked to obesity. So we need to talk about diabesity, because it's completely, I'm not going to say we're talking about the same thing, but we need to know that not all obese people are diabetic, because there are a lot of obese, people suffering from obesity that they are metabolic healthy, but nowadays 95% of the patients that are diabetic, they are obese, or they are suffering from obesity. And that is causing a real burden. Social, healthcare, economical one, and of course, personal one in the patient, the person that is suffering from that. And don't forget that I'm a surgeon, and I need to give my view about the surgery implication in the treatment of diabetes. Definitely, when we talk about diabetes, they have type 1, gestational diabetes, but the majority of diabetes nowadays, 95%, is type 2 diabetes. And why are we having diabetes? Well, because we're eating a lot of carbs, a lot of sugar, even though glucose doesn't cause diabetes. And what's happened is there's an inflammatory response in our body with cytokines, interleukins, many metabolic products that are causing inflammation in our body. That's causing a problem in the cells, meaning that the receptors of the cells start a little bit fed up with so much glucose. So in order to take the glucose, they need more insulin. They need to pour more insulin. So your pancreas has to pour more insulin to get the same amount of glucose inside of the cells. There's a time, like the money in the bank, when there's no more money, when there's no more insulin in the pancreas, is when you start coming and getting your diabetes. In between, you're having what is called the insulin resistance. But what's the insulin resistance? At the end of the day, it's diabetes. It's a stage previous to diabetes, but we need to start thinking about that. Like the insulin resistance inevitably is going to guide you, is going to put you in the way of diabetes. It's causing, look at that, the number of deaths in the world related to diabetes is 1.5 million directly with diabetes. I'm not considering other options like cardiovascular diseases, which are caused by diabetes, or cancers that related diabetes and obesity. There's a higher risk of cancer in patients with obesity. So we are talking about something that is really, really, really impacting us. But I'm surprised because probably I'm giving this talk today. If you go back 10 years, less data, but we're on the same page. And the same, we know what's going to happen. We knew that was going to happen. We're still talking, but nothing happened. Think about close to $1 trillion US dollars expenditure related to diabetes. 500 million, half a billion adults are living with diabetes, much more nowadays. And look at the deaths. In 2021, 6.7. COVID estimation is close to 3 million people. 3 million deaths all over the world. And we were crazy. We were, oh, this is incredible COVID thing, which is a pandemic. And we have this pandemic for many years. It takes more than 6.7 million a year. We're still doing the same, pretty much nothing. If we're looking for the MENA region, we're talking about 95 million predicted in 2045, plus almost double, 60% more. About deaths, in 2021, more than 500,000 deaths. And this is increasing. You look at the data, and you are always having an increase. Look at all the regions, and you look at all the arrows are pointing up. All the arrows are pointing up. I don't know if it's working or not. But if you look at the data, the numbers, look at the Africa. An increase in the coming years of 134%. But I'm much more concerned about the MENA region. Is where we are. Is where we have to implement things. We should be concerned about that. 87%. We are more than double. It's called 136 million in 245. And if we don't do anything, that's gonna happen. We get to Kuwait. Well, close to 1 million people living with diabetes. Probably more. And about the deaths, yearly, more than 2,000, specifically related to diabetes. So when we're getting the data, meaning that the patients are dying is because of the diabetes. We don't count on cardiovascular diseases and other diseases that are related to diabetes. And the amount of money we are spending in our patients, so close to $1.5 billion US dollars. And we're trending up, like everywhere in the world, we're trending up. It's a real problem, and has a lot of health-related complications. What about the nephropathy? All diabetes is causing a harm in the small vessels, in the big vessels as well, but in the small vessels, affecting the endothelial cells. You're going to start having a chronic kidney disease. You're going to end up with dialysis, and if you are lucky, you can have a kidney transplant. That's a poor quality of life of our patients, and that's a burden as an economical perspective. What about neuropathies? The neuropathy is causing the food problems. It's causing a lot of poor quality of life for our patients. Skin complications, infections, mental health. Our patients are more depressed, more prone to anxiety. Immune dysfunction. The immune dysfunction, you know that all diabetic patients, they have a lazy immune system. What's the implication? Apart from diabetes, we're operating on patients because of abdominal wall things, or doing any surgeries in patients with diabetes. We know that these patients are at a higher risk of having infections, and probably we're not counting on those complications related to diabetes. Blindness, the most frequent blindness reason for the patients all over the world is diabetes. Cardiovascular disease, we will talk about that later on today. It's nothing good. And it's still related to obesity. Many of you, of course, know what's the way to measure obesity. Is it the best way to measure obesity, the body mass index, BMI? I don't know. It's the one that we have. And when we use this one, probably we can understand each other. And there are different classifications. And you see, according to the BMI, you can be normal weight, and you can be overweight, and then you have the obesity class 1, 2, 3, and according to this classification, we can stratify our patients and indicate a surgery, one medication, or the other. Obesity is the same as diabetes or much more. 2.6 billion overweight, but close to 1 billion people suffering from obesity. And remember, 95% of diabetic patients, they are obese. They are suffering from obesity. The economic impact, in my mind, I don't have that many neurons to talk about so many zeros. I don't know, it's close to $2 trillion US dollars. Look at that, since 1975, triple, 2023. I would like to know if Dr. Jamal wants to invite me in 7 years and I'm alive and you are alive and we can meet together here. It would be great. We're going to keep talking about the same thing. And we're going to keep talking about that. I remember 7 years ago, nothing happened. We are increasing. And that's a big problem. Because you look at the 124 children and adolescents, they're suffering from obesity and from diabetes. What are we doing? That's going to be the next. What are we doing? What are the factors of obesity? The multiple factors. Genetics. Is it genetic? No, it's my family's. I mean, of course, we're genes. We have 20,000 genes in our body. There are 700 genes identified related to obesity. But the real thing is that many years ago, probably you could say that 50% of obesity is related to genes. And it's related to genes because at the end of the day, we are DNA and we are genes. We're proteins that they are codifying and coding in our bodies. But it's not related to obesity. It's related to the environment. It's related to the epigenetics. It's related to everything is happening. What happened from 1975 when we start climbing up into obesity and diabetes? It was a gene disruption? No. It's our relationship with the environment, mainly what we see with the food. Physiological factors, sedentary lifestyle. That's tricky because I've read many papers saying that today we are more active than compared to 40, 50 years ago. I don't know how they measure that, but it's true. We are more active overall, and we're still. So is it true that the sedentary lifestyle is affecting us, is causing obesity, is causing diabetes? Maybe we can discuss that. Lack of education. Lack of education. When I say lack of education, this one is intended to population. People don't know what you are eating. You think you are eating healthy things, and you really don't know, because they're trying to cheat us. And then we are eating things that we think that are healthy, but we don't have the knowledge to know. I don't have the knowledge to know that. But the lack of education is, I'm a doctor. I've been a doctor for more than 25 years, close to 30 years. Let me think about it. In the medical school in all my life, probably I received 2 hours of nutrition. And that's not happening in the new medical schools. They are not having any instruction, any classes, any semester talking about nutrition, which is really important. No more than, I'm not joking, no more than 2 hours, and probably I skipped that class. So why I didn't talk about the socioeconomical context, the diet and marketing? Because it's the food industry. And it's very difficult. It's very difficult to talk to your patients and tell them that you don't have to go, and I'm sorry, I don't have any disclosure, to talk about the Shake Shack, Five Guys, all this McDonald's, Burger King, the French fries and whatever. If you put a fries here and a broccoli here, everybody's gonna, myself, I'm gonna go on and pick the French fries, not the broccoli thing, right? But we are so controlled by the food industry, which is probably one of the most powerful industries, that they can sell us whatever they want to sell us. We are eating now what they want us to eat. You get these nice, beautiful packages where they put low fat, low carb, high protein, and you eat it, and you are eating the E41, the E102, the E471 emulsifiers, a lot of things, the corn syrup, everything but any food. So that's why I think nowadays we are not suffering from obesity crisis. We're suffering from a food crisis. We are not eating food anymore. And to be honest, I'm a surgeon, but I think we should change our minds and start thinking that food should be the treatment. Food should be the medication that we should eat we should recommend to our patients to treat all the diseases that are happening. This is a Netflix documentary. I don't agree with many things they say, but I recommend you can watch it, and you can see both sides to get an idea about what's going on in the world. Probably there are many things I don't agree, and I'm not selling anything, of course, but it's good to know both sides to get an idea about what to think and have your own position regarding the food industry and what's going on. And what can we do? Because every time, probably, we cannot do anything, I don't have an access to the government, I'm not creating the policies, I'm not creating anything. Well, but we can do a lot of things at your own level. I mean, I'm not thin, I'm a little bit overweight, and I tried many things in my life. I've been vegetarian for a month. I couldn't last longer. But it's true, I have to tell you, I'm honest. This is my studies N1. It's myself. And I have to say that I never had superpowers, but I felt much better. I went back to the animal protein and so forth, definitely. But eating healthy stuff and vegetables made me feel much better, less inflamed. And I'm not joking. Every time in the morning when I woke up, I didn't have any pain. That I've been suffering, and now I have that pain again. And I'm not changing. But you can change yourself. And what about your family? You have your kids, you promote your kids, and it's up to us to let them call Talabat once a week, not once a day. And those are problems. We can work on many things with that. And we can work with our patients. And we can work in the schools. Because definitely, I can talk about surgery as the best option, and I'm going to defend that as the best option. Probably from your side, if you have endocrinologists, internal medicine, family medicine doctors, everyone is going to defend their part, right? No, medicine is better. I'm going to say that surgery is better, but that's not the treatment. That's the patch. That's the patch that we have to deal nowadays. But we need to invest our efforts in prevention. And the prevention comes as an investment for 20 years. It's an investment in the schools. It's an investment with our kids, with the child. If we don't change that, I can tell you in 10 years we'll be here talking about this, and instead of 1 billion people, we're going to see 2 billion people suffering from obesity, diabetes, a lot of problems and complications. So, and what's obesity or diabesity? Which is this. Again, we were talking about until we heal our pancreas, until we heal our bank account with our insulin. A little bit more complex than that. And it takes a while. It takes a while. It takes a while since we were kids, eating things that we shouldn't eat. Many things that we can do about it. If you look at how obesity and diabetes affects our bodies, we get in the middle. And we share most of the complications and problems, the neuropathies, the nephropathies, cardiovascular disease, but what about food complications and joint complications that can happen in obesity? It happens as well in diabetes, or in type 2 diabetes with gastroparesis, or gastrointestinal issues with obesity that we're having. Dyslipidemia, we cannot breathe. So these two circles, they're going to merge, and there's going to be a time when there's no difference. And it's going to be almost the same. What about bariatric surgery? We can talk about the GLP-1. I put the GLP-1, PYY, and oxytomodulin to pretend that I know about these things. Those are complex things for a surgeon. We are more than cut, paste, and do that kind of stuff. But definitely surgery works. Surgery works. And that affects in different levels. Of course, we do surgeries, as Dr. Cross said before. Sleeve gastrectomy, we create some restrictions. We cannot eat that much. It is going to make us lose some weight. That's going to change the microbiome of our colon. That's another thing I want to talk. I'm really on the microbiome thing. We've been living all our lives not looking at the microbiome. We have 3 times more bacteria in our colon than cells in our body. That's what it is. So, and probably it's much more important than our brain, our heart, and everything is coming from your colon and the bacteria in your colon. And don't forget that we need to feed those bacteria. We need to feed them, and now we're not feeding them. We are mistreat them. And that's why we are having so many immune diseases. That's why we're having a lot of obesity. That's why we're having a lot of diabetes. That's why we're going to increase the number in cancers. So it's a big problem. And I'm saying that. So how can you cure diabetes? With surgery. This is a very well-known paper from Dr. Porris, published in 1995, after their experience since Dr. Mason performed the first gastric bypass. So it can be cured. It can be cured. Do we cure? No, I'm not saying that, but it can be cured. And many times it's much better than other medications. Like this cartoon from Dr. Porris. So my dad treats diabetes. My mom is a surgeon and cures it. So we have the chance. And this is for the subliminal effect to my colleagues in endocrinology, internal medicine, that not only medications are working. And of course, obesity, diabetes is not only one treatment. Because we saw that there are a lot of factors that can affect and create diabetes and obesity. So we need to treat in different aspects. It's not about, I only treat with medications because only medications work. I'm only treating my patients with surgery because only surgery works. I think we should work together. We should work together. We should combine our therapies, and everything is in our hands. Of course, again, why don't you randomize me into the surgical group? Because, to be honest, it's the only one that works. That's hilarious, but we need some science. This is a Stampede study published in the New England Journal of Medicine by Dr. Schauer when he was in Cleveland Clinic. And they compared the medical treatment versus bariatric surgery, sleeve gastrectomy, gastric bypass. This slide is from Dr. Ali Aminian. And look at that, this Stampede work. You don't need to know a lot. You look at the bars, and you see the yellow one is the medical approach. And the other two are the sleeve gastrectomy and the bypass. How does the bariatric surgery affect the hemoglobin A1C? Well, it's a huge difference, significant, compared to the medical court. If we look at a change of BMI, and in 5 years, it's not in 2 years, definitely there's an increase of weight after 2 years. Could be some failures. But you look at the data, and there's a huge difference between the medical treatment and the surgical one. And what about adverse events? Of course, if you look at reoperations, the medical field, they don't have any reoperation, which is normal. But if you look at the bypass sleeve and medical therapy, there are not huge differences. And probably we never know how much improvement and how much quality of life we gave to all those patients, even though they went through complications after surgery.
3 minutes.
This is a study by Dr.
Doctor, 3 minutes.
Sorry?
3
Okay.
minutes.
It's fast. Between Dr. Mingron and Francesco Rubino in The Lancet, again, it's a randomized controlled trial, open label, compare the same. In a medical treatment, we don't see any remission. You see there's no bar because there's no remission. There's a huge remission between bypass and a bilipancreatic diversion. After 5 years, reduces, but we have it. Cardiovascular drugs, number of tablets, is decreased in the surgical group. It's not decreased in the medical one. Cardiovascular risk, it's significant, and there's a less cardiovascular risk in the surgical group and not in the medical group. All-cause mortality, compare bariatric surgery in diabetic patients with control patients with diabetic patients. And you look at that, and the all percentage of patients who died, they are much more in the control group, no medical, with the medical group, than in the surgical group. In the surgery, which one is better? Well, if you go to duodenal switch, SATI, we're talking about room-wide gastric bypass better and better than a sleeve. But all of them, they're working properly. So the majority of the surgeries that we're doing nowadays, this is from ACMBS. 10 years ago, we can talk that the gastric bypass was the most frequent surgery. Nowadays, changed completely. Now a sleeve is the most frequent surgery, as you can see in this slide. But this is last slides. Long-term diabetes remission in type 2 diabetes. If you compare bypass with the sleeve, in these 3 studies, Stampede from the States, Sleeve Pass is from Finland, and SM Boss is from Switzerland. All of them, they have a good results achieving a complete remission of diabetes, and this is surgery one. How could we make decisions in our clinic? Well, this is a tool that we can use. It's a calculator tool that we can download. It's created at Cleveland Clinic, where we measure the metabolic risk of the patients, and according to this, we can decide. It's a tool. It's not mandatory. It's like an advice. Which one is better for our patients, sleeve or bypass? I don't know which one is better. What is better is that if we can work all together to help our patients. This is not about surgery is the best. This is not about medical treatment is the best. It's about that all together we should work to give our patients the best treatment. Thank you very much. This is our beautiful hospital in Cleveland, in Abu Dhabi, Cleveland Clinic Abu Dhabi, and you are more than welcome to visit us whenever you want.